So device-detected AF. Here are my disclosures again. So we're talking about device-detected AF because it's an interesting topic in and of itself, but here in the context of this session, should we be looking for infrequent and low-burden AF in our screening programs? And I want to start by stepping back and thinking about clinically detected paroxysmal AF. And it is curious that we have recommended for years now that paroxysmal AF, clinically detected, should be viewed as equivalent to more persistent AF in terms of stroke risk. And that came from the pooled warfarin trials. But more recently, this is being readdressed, and here's some good data from the pooled aspirin analysis of active and Averroes trials. And you can see that the rates decrease from permanent to persistent to paroxysmal. So this is a little bit of information suggesting that clinically detected paroxysmal is not really equivalent to more permanent AF. So again, stepping back, why isn't stroke risk just directly proportional to the clinical AF burden? Right? We started and said paroxysmal is the same as more persistent. Well, the true AF burden may be 10 times clinically detected burden. We have evidence to support that assertion. The return to sinus rhythm may acutely raise risk. And atrial fibrillation episodes may permanently alter the left atrium or the left atrial appendage to form a more prothrombotic environment. That's a non-transient effect. Atrial fibrillation of any type is just a marker for a separate process that itself is prothrombotic. AF is not the cause. Well, this is an old saw, and it continues in all discussions. I don't think it holds much water. We need, to address these issues, we need continuous heart rhythm monitoring to fully understand the relationship between AF burden and stroke risk, and a lot of that information comes from implanted cardiac devices. And here's a slide that I borrowed from Jeff Healy at the recent AHA. And the ASSERT-2 study was 254 patients with ILRs, and this is 18 months of follow-up. And you can see if you subclinical AF SCAF at a low threshold, 5 minutes, a third of patients. This is an enriched population. They're older and they have some risk factors for AF, but there's a lot of AF. On the other hand, as you raise the threshold for calling it positive, you get fewer and fewer patients. And the other thing to keep in mind is that most of the time that these patients are alive is in sinus rhythm. So device-detected AF, I'm going to review 3 observational studies and touch very quickly on 2 trials. These are the studies we'll talk about. There are other studies that I'm not addressing, but I think they're consistent with the principal points I'm going to make. So the TREND study, this was 2,486 patients with implanted devices. About half were pacemakers, and pacemaker patients are much more like standard AF patients. The exposure was ATAF, a 30-day window. That is, you had to have more than 5.5 hours of AF on any given day within 30 days. And the outcome was thromboembolism, ischemic stroke, TIA, or systemic embolism, and these were adjudicated. The follow-up was a mean of 1.4 years. And here's the distribution of 30-day windows, and you can view this as distribution of person time. And no ATAF, the vast majority of people had no ATAF. And 5.5 hours was the median, so we know that half of them had more and half of them had less. And the basic point I'm saying is in this population, there were not that many long episodes of AF. Here are the results. There were 40 thromboemboli, 20 ischemic strokes, and there are very few events. And these studies consistently show very few events, and I think there's a message there. 73% occurred with no AF in the preceding 30 days, and I'll address that kind of puzzle. And here's 0 ATAF burden, low and high. Here's the thromboembolism rate, right? And now if you just focus on strokes and exclude TIAs, you get much lower rates, but the same pattern, and the adjusted hazard ratio was 2.2 if you went over that median of 5.5 hours on any given day. It wasn't quite statistically significant. Okay, so what are the implications of the TREND study? In implanted cardiac device populations with little AF, the rates of ischemic stroke are low, and most ischemic strokes are not preceded by episodes of AF. However, multiple hours of AF about doubles the risk of ischemic stroke, and this effect appears to last for 30 days after the episode of AF ends. What isn't appreciated widely from the trend study is that at 31 days, the exposure goes back to background. So at 31 days after the episode, the risk of ischemic stroke reverts to background. Here's the ASSERT study. Does subclinical AF during an initial 3-month period raise subsequent ischemic stroke risk? 2,400 patients, mainly with pacemakers, follow-up 2.5 years. 261 had subclinical AF in the first 3 months. Here's the definition. Here are the results. 3-month SCAF, there were 11 events. Again, very few events. Here's the stroke rate. No 3-month SCAF. Here's a stroke rate. And the adjusted hazard ratio was 2.5. And this is where people say, well, if you had more than 6 minutes of subclinical AF, you've raised your stroke risk. Well, if you look at the rates in the long-term follow-up, you can see that most of the increase in stroke risk, here's quartiles of follow-up hours, less than 0.86 hours to greater than 17.7 hours for the highest burden. And you see the stroke rates are really increased in the substantial AF burden quartile. I don't know I guess you can see this. This is the New England Journal paper. This is a curious thing. It's the first 3 months are out here. Did you have more than 6 minutes of SCAF? And then nothing happens. The blue line is the subclinical. Nothing happens for about a year, and then the strokes accumulate. So subclinical AF in the first 3 months predicted stroke months and years ahead. Subsequent analysis found that no ATAF there was no ATAF prior to most of these strokes, and it raises this question of does AF cause a prothrombotic state that persists even after sinus rhythm returns? This is the VA CareLink study that I was involved in. It's an assessment of the relationship between device-detected AF and stroke, and we felt that the biggest problem was they didn't have enough events. So how could we maximize the number of events? The study sought to identify as many ischemic strokes as possible among patients who had 120 days of continuous heart rhythm monitoring immediately preceding the stroke. And we compared the stroke patient's rhythm pre-stroke with the rhythm during an earlier non-stroke period. This is called a case crossover analysis where the patient is his or her own control. And I'll show you a lot of the data. So does AF transiently raise risk of eye stroke? To get the numbers up, we linked the VA databases, 9,850 patients with implantable devices, to Medtronic's CareLink database of heart rhythm records. We found 187 patients with acute ischemic stroke with 120 days of heart rhythm records. And we compared the AF burden 1 to 30 days pre-stroke versus days 91 to 120 pre-stroke. The patient is his own control. So most stroke cases, and we used AF burden to find it on the basis of trends, 5.5 hours a day. Most stroke cases, as in all these studies, had no AF. 15 had AF more than 5.5 hours in both periods. So these two groups are non-informative. But there were 16 discordant cases. 13 were positive in the case period, and that leads to a calculation of adjusted odds ratio of 4.2. Now let me show you, this will give you a better sense of it. Here's the displays. These are 10 individuals randomly selected from the 156. This is the negative. The red line is when they had their stroke. This is the case period. This is the control period. And you can have up to 24 hours of AF in any given day. And as you look on here, it's a desert. It's an AF desert. And you see one little blip here. And if you're positive, most of these people had lots of AF all the time. But here are the informative cases. Here's the positive, negative, 13 cases. This is the red lines, the stroke. You can see their AF in the prior 30 days, just immediately preceding their stroke. And if you look back at the control period, there's nothing. There's a little blip here. And what about the negative, positive? There's nothing here pre-stroke, and a little bit of AF back here. So this is the nature of the data. One of the interesting things is we looked at 5-day periods. Now this is very low power analysis and the confidence intervals are very high. Here are the days, 1 to 5, 6 to 10, and so on, and here's the risk. And you can see that the risk is highest immediately following, during or following the episode. And then it reverts more or less back to baseline by about 30 days. So the conclusion here is that multi-hour periods of AF acutely raise ischemic stroke risk, and this risk diminishes over about 30 days from the end of the episode. So even prior to this study, people thought, well, let's use a transient anticoagulation strategy for people with transient or paroxysmal AF, and the IMPACT study did that. Unfortunately, it used warfarin, which is really not a good agent for rapid on and rapid off. And the two, again, these were people mainly with ICDs and CRTD devices. The continuous home monitoring, start and stop rules, conditional on the CHAD score. The higher the CHAD score, the less AF they let the patients had before they restarted anticoagulants. And then the control arm was clinic visit downloads, anticoagulation up to the physician. And the problem here is not only was the agent, warfarin, awkward for this protocol, but it was a little bit vague in terms of from my perspective, in terms of the separating the two interventions. And the results were indeterminate. There was little AF, the same very low event rate in both, same use of oral anticoagulants. So it's not much, and it was stopped for utility. Rod Passman has published this pilot single-arm trial of Reveal XT, use of NOACs. Now, NOACs are a much better agent than warfarin. Test whether this approach preserves stroke prevention while reducing exposure to OAC and bleed risk. And the protocol was, if no AF in 30 days, discontinue novel anticoagulant, use aspirin, restart if there's as little as 1 hour of AF, and continue for 30 days after the episode ends. And the results, again, it's a very small one-arm study, 59 patients, 18 patients had 35 episodes of AF. There was a 94% reduction in the use of NOACs. There were no strokes. There were some TIAs. And it suggests that in patients with very low AF burden and low stroke risk, intermittent NOAC strategy may reduce exposure to NOACs while preserving protection against stroke. And it needs a definitive randomized trial. Well, you should be aware that there are at least 2 large randomized trials addressing the firm finding, which is once you find subclinical AF of here more than 6 minutes, then you start people on anticoagulants and they stay on it. This isn't an on-off strategy, this is a stay-on-it strategy. So it's pacemaker or ICD in place, subclinical AF 6 minutes to 24 hours, and a very high CHAD score. And this should be 5 milligrams BID. It's the standard apixaban. And it's in process. There is as well a German-based study, the NOAA trial, which is doing more or less the same thing, but in this case using edoxaban. So let me conclude. There's good evidence for an acute rise in stroke risk starting with the onset of AF and tapering off after the end of an AF episode. Whether there's residual increase in stroke risk after an AF episode is not clear, but I don't think it's most of the risk. The exact relationship between AF burden and stroke risk has not been defined, but it's likely that short episodes, and here I'm being very conservative, less than 1 hour, confer much less stroke risk than permanent AF. Anticoagulation following multi-hour episodes of higher-risk patients makes sense. The net benefit of this strategy will be determined by ongoing trials. Whether oral anticoagulants can be stopped safely 30 days after AF ends needs to be tested by randomized trials using novel agents. And as regards screening, so this all addresses the issue of how do we approach stroke risk with subclinical AF, device-detected AF. But as regards screening, I think the answer here is that the goal should not be to find, to have prolonged screening to identify brief, infrequent episodes. The goal should be to find higher burden AF. Thank you.